All right, guys. Let's begin. Yeah. So we have a scenario on oral thrush in infant. So what was the scenario like? That you are FY2 in GP surgery, and the mother, Jennifer, she's 26 and she has come to you because she's worried about her child. Child is 5 months old. Why she's worried? Because she has noticed something white coating on the tongue, and that's there for 1 to 2 weeks. And that was the reason she is worried, right? The aim is, the station is talk to her, assess her, and manage the kid, right? Many a times you'll see there might not be enough information given to you in the question. The question might say that mother was worried because of her 5-month-old child. Just go and talk to her. So they may not be giving you enough information in the question, but sometimes they do mention the presenting complaint in the question itself. All right. Then what you do, you go and start the station. How can I help you? And she started that I have noticed something whitish on my baby's tongue, and it's there for last 2 weeks, and I'm really, really worried. Something whitish on the tongue, right? So now what do you think? What are the questions that we should be asking? So there's a whitish thing. So what you do, you try to elaborate it. I mean, doing a bit of odipara, onset, right? The duration, 2 weeks that we know, anything making it worse, anything making it better. So just do proper elaboration of the presenting complaint. Right. And what we got to know that 2 weeks and it's getting worse. That's the main thing, right? And what else you think we can ask? So once you are done with the elaboration of this oral thrush, we need to ask some more questions like it's on the tongue. So if he's able to eat or drink or not, right? So in kids, that's the main thing that you need to ask. If the child was able to eat or drink, any signs of discomfort or mainly the problem in feeding, if he was eating or drinking well or not. So that's the main question, right? Now, if it's yellowish, so I mean, it's a whitish, so you can ask, for example, if there was any fever or not, right? That's the main thing. And in this country, they are very keen if you are ruling out meningitis or not. So make sure maybe one question about neck stiffness, shyness to light. That's something you can do, right? And then obviously rule out other infections as well. Maybe UTI if is crying while passing urine, any diarrhea or constipation. So these are the things that you can ask. So these will be important, right? So whitish thing on the tongue. I think when you hear this word, what comes in our mind? It comes in our mind is like it could be fungal infection, isn't it? Thrush. So that's the first thing that even it comes in our mind as well. So maybe you can ask any kind of rash anywhere else in the body because if a patient has got oral thrush, they might be having something in around nappy area as well. So that is also something that we can ask, right? So always in the child, ask if the child is able to eat or drink well, any fever, meningitis, UTI, just quickly rule those things out, right? Then obviously past personal psychosocial history, who's looking after the kid, how was the birth of the child, all the birth history, that's something that you can take, right? So once we are done with it, then what you need to do is examinations. I would like to do general physical examination, vitals, and obviously I would like to do the oral cavity examination as well. And this is the picture you get. So this is the whitish thing on the tongue. That's what the mother is talking about. So what is it? It is oral thrush. So now what we need to know is what are the main risk factors here. So what are the risk factors of getting oral thrush in a kid? Number one is maybe the child is immunocompromised, right? Immunocompromised child, right? Number two is maybe there is a use of, say, recent antibiotics, right? Or immunocompromised, I said, well, even if you not keep it separate, maybe there is a use of steroid for any reason, isn't it? What else? We need to see if the child is being breastfed or not. So breastfeeding. Why this is so important, the breastfeeding part? Because maybe mother has got this fungal infection that might be transferring to the baby as well. So you need to be very careful on that. And one of the most important thing is child might be using the dummy, the pacifier I'm talking about, or the bottles for the milk and all. So are they properly sterilized or not? So these 4 or 5 reasons I definitely want you to look after when you get a case on oral thrush in a child. If the child is immunocompromised or not, maybe taking steroid for anything, and maybe has taken the recent antibiotics, or maybe breastfeeding, mother might be having the problem, right? And dummies, bottles, maybe they are not sterilized properly. So this is something you need to try finding in the history itself. And to be honest, when you see this picture, I think it's easy for you to make the diagnosis. What we're looking for is the oral thrush only. Right. So from our assessment, we are suspecting oral thrush, and it's common in infants around 6 months. So it's caused by yeast candida and appears as a white patches, may cause mild discomfort, but it's not dangerous and often triggered after antibiotics, right? So all these risk factors I have mentioned. So when you take history, you might be able to find something. So you'll be able to blame something. Okay, this might be the reason in your baby's case. Right, so what's the treatment? The treatment is obviously you need to go for the medications, that is nystatin, that is oral suspension, or miconazole, oral gel. That's what you can give, right? 1 ml 4 times a day, use dropper to apply directly in the mouth, and you can continue for 48 hours after the symptom clears, right? Or alternatively, we can go for oral gel as well. So that is the treatment plan. So that's the first line of treatment you will be able to give. Now, the main thing is what the mother should not be doing. Don't try to scrape off these white patches. It is gonna go on its own, right? Avoid sugary drinks or sweet dipped dummies. That's the thing, because it's gonna make things worse. Yeah. General advice is continue the regular feeding. Just confirm whether it is breastfed, whether the child is breastfed or the bottle fed. Bottles, if they're sterilized properly, and if it is breastfed, then you need to see if the mother has got an infection or not, right? So continue regular feeding. Breastfeeding mothers clean nipples, let air dry, sterilize bottles, dummies, and teats thoroughly, and when to seek further help. So always in any station, whatever you get, follow up and warning signs. These are must. When are we supposed to be alarmed? That's very, very important. So how long it takes to get better, first of all? I mean, the mother is saying it has already been 2 weeks. So what we can say is, I mean, once we started the treatment, it should be okay within a week or so. So if there is no improvement in 7 to 10 days, maybe you can come back. And obviously the child is not eating or drinking. So that will be a red flag sign. So that's another one. And if you feel that it's getting worse, the rashes and all, if you feel it's just getting worse, and if there are recurrent episodes of thrush, maybe you can bring your child back, right? So that's what we have got in oral thrush in infants. All right. Okay. Sensory ataxia. You are in GP surgery. Patient is 35, presents with lower limb weakness. Talk to the patient, assess him, and discuss the management. Okay. Now, the thing is, when you get these kinds of station, I would say there will be a lot of confusion, or there'll be lots of differentials, I would say. And a lot of us are thinking whether it is cerebellar ataxia, it is sensory ataxia, it is GBS. So let me have a bit of discussion about everything, then we will make your life easy. First of all, let's discuss about the differentiating features between GBS, Guillain-Barré, and cerebellar ataxia. Let's have a discussion on it first. So first of all, in Guillain-Barré, you will see it's a rapid onset and usually within the days or weeks. Yeah. And whereas in cerebellar, it's going to be gradual onset and it may take few weeks, months, or years to develop, right? Guillain-Barré, you will see it's an ascending paralysis. It's an ascending paralysis, right? It starts from the legs, and then you will see the weakness might be there in other part of the body as well, and then later on can involve the lungs as well. And patient might be needing the ventilatory support as well. Patient might have problem in swallowing, and all those things that you will see. Right. So symptoms mainly in Guillain-Barré, you will see weakness and tingling starting in the legs and progressing upwards. That's why we say it is ascending paralysis. May affect the arms, face, and respiratory muscles. Whereas in cerebellar ataxia, what you'll have uncoordinated movements, difficulty with the balance, coordination, and it might be affecting the limbs. Progression, that is rapid deterioration of the motor function, and later on can lead to paralysis as well. Okay, here you will see slowly it's gonna worse and often fluctuate with certain activities and all. Usually in Guillain-Barré, what you will see, patient had a fever, and after that patient started having this weakness. So you'll have something, some preceded illness. That's really important. If often follows a viral or bacterial infection. Infection could be, say, gastrointestinal GI infection or respiratory infections. And after that, patient might have this weakness. But this one is not, this one can be infection, but rarely. Mainly there might be any genetic condition or maybe alcohol use or any toxins. Yeah. Reflexes may be absent reflexes, right? But in cerebellar ataxia, you might be having normal reflexes as well. Motor versus the sensory. Primarily motor weakness with minimal sensory loss. That's what you have in your GBS. It is mainly the coordination problem, cerebellar ataxia. Duration symptoms often progress very rapidly, very rapidly. But the improvement takes time. Symptoms will come fast, but then it's gonna go very slowly. All right. So symptoms often progress rapidly, but plateau after a few weeks, and then improvement is gradual. Yeah. Symptoms tend to persist and may worsen over time without specific intervention. Yeah. Risk factor, as we discussed, mainly is a recent infection. Sometime after vaccination, again, patient can have fever and all, and that can be the reason patient might have a GBS later. Here, it's genetic condition, maybe alcohol use, as I've already mentioned, and maybe vitamin B12 deficiency as well. Treatment is patients usually improve, and you might be doing the plasma exchange or immunoglobulin therapy. Here, you need to find out the cause. What's the cause? Is it vitamin B12 or is it something else? And you will be able to manage the patient accordingly. Right. So this was a table briefly differentiating these two things, GBS versus cerebellar ataxia. Right. Now, the scenario that I'm going to discuss is sensory ataxia. So how are you going to differentiate between sensory, cerebellar, and other things? Let's have a look. So patient is 35 having weakness in lower limbs. Go and talk to the patient, assess the patient, discuss the management. The patient is saying, I've been having the weakness in my legs over the last few days. Okay, tell me more about it. So what we're going to do when patient says I've got the weakness, just elaborate a bit more, maybe doing more of Odipara. What exactly does it mean? Patient is having heaviness, patient is feeling tired as well. Is it one leg or both the legs? When patient says both the legs, it means it's not something local, it's some systemic problem, isn't it? So that's really important. Now, what you have to do is you have to check for the coordination as well, like if there is any problem with the coordination or not. So do you feel like losing balance? Any trouble with the coordination? Any problem with your bladder or bowel? This patient is saying no. And any pain, there is no pain as well. What this patient is having just the weakness in the legs, feeling the legs are a bit heavy and feeling generalized tiredness as well. That's the only thing this patient is feeling. When I tried asking about cerebellar signs, most of them, they are negative. Okay, that's fine. We can do the examination as well, and then we will see if it is cerebellar, sensory, GBS, what exactly is happening. Now for GBS, okay, we said usually we find there is a preceding illness, isn't it? So that's what we tried asking. Any fever, flu-like symptom? Patient is like, no, doctor. Any shortness of breath? Why are we asking shortness of breath? Because we know if it is ascending paralysis, it's going to involve your lungs as well at later point of time, isn't it? Any shortness of breath? No, doctor. Have you noticed any tingling, numbness, getting bored, or spreading upwards in your body? It's a straightaway question we're asking for GBS, and patient is saying no to that as well. So where this station is going, I mean, there is weakness, heaviness, tiredness, but no signs of cerebellar. I mean, if you see coordination problem, bladder bowel problem, it's not there at all. What's happening? Let's see. Quick past personal history also you will take, and no medical condition, no medication. And you see this patient, when you ask for the diet, this patient is vegan, because you have to be very careful about vitamin B12 as well. When I was discussing about this slide, you must have seen here, the treatment depends on the cause, and one of the cause could be vitamin B12 deficiency as well. So that's why, I mean, this could be very important if your patient is vegan only. Yeah, so that's very important. Any drugs and all, this patient is, when you ask any recreational drug by any chance, the patient is like, no, nothing dangerous. But when you go, nothing dangerous, what do you mean? It means you take something. The patient said, I use nitrous oxide. I'm using nitrous oxide. How much? It's about 100 canister a week. 100 canisters a week. The small canisters you will see for nitrous oxide. The patient is saying, I've been using nothing serious, but using nitrous oxide around 100 canister per week. All right, then what I'm supposed to do, I'll do eyes, I'll do general physical examination, vitals, and be doing the neurological examination, cerebellar examination I'll do. Now what happened? My dear examiner said that, for example, Romberg test is positive. Romberg test is positive. See, Patient is standing straight, eyes open, and if patient is swaying here and there, it is cerebellar ataxia. But if patient closes his eyes and then he's not able to stand properly, and if he falls down with eye closed, that is sensory ataxia. Whenever we say Romberg positive, Romberg test is positive, it simply means sensory ataxia. Sensory ataxia. And sensory ataxia usually you have got proprioception is also impaired in the lower limbs. And that's what our dear examiner gave us in the finding. So I would like to do general physical examination, would like to check the vitals, and would like to do focused neurological examination, cerebellar examination. Romberg test positive, proprioception impaired in both the legs. What is it? What is it? It is sensory ataxia. Right, and obviously I would like to do the vitamins, vitamin B12, folate, thyroid function test as well, and checking the full blood count as well for any infection and all, right? And maybe the NCV and MRI. Why this is done? Because the patient has got the weakness in the lower limb, so nerve conduction study, that might be a good idea. And if you're thinking any sensory or cerebellar ataxia, what's happening here? So we will be considered doing a CT or MRI as well. Why I said it's a sensory ataxia? So from our assessment, your symptoms suggest a condition that is sensory ataxia. This means your body has a difficulty sensing where your legs are. It can lead to the problem with the balance, especially when your eyes are closed. That's the main thing. Eyes open, patient falls down, patient fell down, patient falls down. That is cerebellar. Close your eyes, and if patient falls down, that is sensory ataxia. All right. So now conduction study and MRI, CT can be done. Now, what's causing? What is the main cause here? Who is causing? What's the problem? So, common cause is vitamin B12 deficiency. That's what we got. So, vitamin B12 is essential for keeping your nerves healthy. That we know. And without enough B12, you may experience this numbness, tingling, unsteadiness, leg weakness. So, that's something that can happen. Who is at risk? Person who is vegan will be at risk. And if you're taking a recreational drug like nitrous oxide, what this nitrous oxide will do, this gas stops your body from using vitamin B12 properly. The thing is, this patient has got low vitamin B12. Why? Because of vegan. Obviously, I haven't done the investigation, but hopefully, with the history, what I'm thinking, it's vitamin B12 deficiency. On top of it, if somebody is taking nitrous oxide, it's gonna make things worse. The gas stops your body from using vitamin B12 properly, right? And it can lead to the deficiency, even if your blood levels looks normal. So that's the problem. Right. And now we need to treat it. What's the treatment? With treatment is straight away. So treatment is what? Number one is stop using nitrous oxide. That's one. And start vitamin B12 injection. Hydroxycobalamin injections we have to do every other day. Usually for first 2 weeks we give, but every other day you need to give, right? And then we will monitor the symptoms. If the symptoms are getting better or not, we might be referring you to the neurologist as well. Physiotherapy maybe, that's important as well. And once even the vitamin B12 injections you have given, I'm not sure whether the patient is going to continue with the vegan diet or not, because you can't force the patient to go for a non-vegan diet. So maybe if that's the case, maybe we can tell the patient to go for vitamin B12 supplementation as well. Dietary advices accordingly, right? And always, you have to know, follow up and warning signs, my friend. It's the most important thing. So if the symptoms are getting worse, make sure you can come back to us. All right. Now, in this case, the main thing that we are really worried about is if it is not treated properly, what it can lead to. So, what can happen without the treatment? So, these things can actually lead to subacute combined degeneration of the spinal cord, SCTC, subacute combined degeneration of the spinal cord. So that's the thing we are mainly worried about. And what's going to happen if this is going to be there? Loss of balance, numbness or tingling, leg weakness, gait disturbance. So we need to be very careful about it, right? And if the patient has got vitamin B12 deficiency and folate deficiency as well, vitamin B12 and folate, which one you will treat first? Your patient has got vitamin B12 deficiency and folate deficiency. Which one you will treat first? So B comes first, isn't it? A, B, C, D, B comes first. So make sure you treat B first, vitamin B12 first. Right, so this was what I wanted to discuss in sensory ataxia, cerebellar ataxia, and GBS. All right. Okay, next, Kawasaki. So before I actually jump into this Kawasaki, let's discuss a bit more about Kawasaki versus scarlet fever. What is Kawasaki disease and what you might see in scarlet fever? So Kawasaki cause unknown, possibly an abnormal immune response to infection or the environmental factors, whereas scarlet fever, bacterial infections, group A, streptococcus. Yeah. Now, the Kawasaki you will see in children under 5, whereas scarlet you will see a bit older, like 5 to 15 years old children. Yeah. Here, what you will see the fever lasting more than 5 days, but here you will see fever might be high, but resolves 3 to 5 days with antibiotics. So you will see the patient is going to get better soon in scarlet, whereas in Kawasaki, it might take a bit longer. Swollen glands in the neck, now, swollen glands, what I mean by that, lymph nodes. But remember one thing for the lymph nodes, for Kawasaki, what you will see, it is enlarged, painful, but the main thing is it's unilateral. It's unilateral in Kawasaki. Whereas in Scarlet, you will see it is bilateral and less prominent. So uni and bilateral, that's also one of the differentiating feature, I would say. Yeah. Um, what else you'll have will be dry, red, cracked lips, strawberry tongue. But the thing is, here also you'll have a strawberry tongue. It may not be very easy for you to differentiate on the basis of strawberry tongue. It might be in Kawasaki, it might be in scarlet fever as well. Another thing that you will see here, the rash. Here, what we say in scarlet fever, the rash is like a sandpaper-like texture. Sandpaper-like texture. This is what I was talking. Sandpaper-like texture. Whereas if it is Kawasaki, this is gonna be the rash-like, a generalized kind of rash. But if it is looking like a sandpaper-like texture, that's more towards a scarlet fever. Yeah. Okay, and Kawasaki can lead to the heart problems. That's the main thing we need to be worried about because the child is less than 5 years and can have heart problems. So maybe you have to refer the patient to pediatric cardiologist as well. That's really important, yeah. And this one can also affect the heart, kidneys, and other parts of the body. But Kawasaki mainly, I'm worried about the heart. Now the treatment is you will give IVIG, and aspirin. See, mostly you will see in most of the stations, we say you should not give aspirin to children because if you give aspirin to children under 16, it can lead to Rey syndrome, isn't it? But the problem, not the problem, I mean, the main part of treatment for Kawasaki is you have to give aspirin, right? So you have to give aspirin, IVIG and aspirin. Sometimes when you see patient has got fever, maybe somebody has started the patient on antibiotics, but you won't see any improvement with antibiotics because it's not a bacterial infection. It's not contagious as well. Right. And here in scarlet, what is going to happen? The antibiotics, that's going to make things better for you. Right. And it's highly contagious. So you have to be very careful because it spreads through respiratory droplets. Right. So that's your strawberry tongue in Kawasaki. That's also strawberry, but this is something you might see in scarlet fever. And this is a sandpaper that you will see in scarlet. Unilateral lymphadenopathy you will see in Kawasaki. Whereas if it is bilateral, you will see in scarlet fever. Have a discussion on this topic. Let's see. So, you are in a GP surgery. The child is 3, has a right-sided lymph node swelling and a fever of 38 degrees. The nurse has completed an initial assessment. The child is with the mother in the other room and the father is present for the consultation. So, talk to the father and discuss the management. So, when you see this, what comes in our mind? Obviously, there are so many things. I mean, it's first of all unilateral lymphadenopathy and fever. So what I'm going to do, I'm going to elaborate on the fever. I'll see what is the source. I mean, if it is any cough, shortness of breath, and all those things I'll cover. And then I'll ask about UTI, crying while passing urine, any diarrhea, any constipation, meningitis. I'll be making sure I'm ruling out that thing. Another thing that I'll check if the child is eating, drinking well or not. So these are the main things that you need to do. Anything else, and now you'll see the child might be having this red tongue, right? Strawberry tongue as well. So that is going to be taking you towards the diagnosis. So how can I help? The Daniel is been unwell for the past few days, 5 days. What does that mean unwell? Is a fever. Is having fever and is not able to go to the nursery as well. Okay. Did you check the fever? Yes, it's 38. Did you do something? Yes, I gave the paracetamol and it's getting, I mean, it's not, not working properly. Any other symptom? Yes, he got the rash as well. His body looks swollen generally. Okay, rash, where exactly the rash? Kind of over the whole of the body, he developed the rash. Eating, drinking well? Yes. And any swollen glands? Yes, on the one side of the neck. The thing is, swollen glands on the neck, the parents, they may not have found it out. So if the father is saying, no, I haven't noticed any swollen glands, then still it's fine because I've got that information in the question as well because the nurse has already done the assessment and the findings of the assessment has been given to you in the question itself so that we can easily make the diagnosis. Yeah. And any recent infection? Yes, 2 weeks ago he met with the cousin. His cousin was having chicken pox. So sometimes what they do, they try to confuse you, chicken pox. So you might be going towards chicken pox only. But you have to be very careful. Strawberry tongue is not there in chicken pox, isn't it? Then what you do, you quickly do bird history as well. Yeah. I would like to do general physical examination, vitals, full blood count, and the throat swab. Fine. Now, what you have to do is you have to ask for general physical examination vitals, and obviously you want to check the rash. This is what they show it to you. These are the two pictures you get in the exam. So this is what you have. So strawberry tongue, and this is the rash. So what it looks like, these two pictures, if I give it to you, and the history that you have got, where it is taking you towards. So based on your symptoms, your son's symptoms, fever is more than 5 days, rash is there, swollen glands, ipsilateral one side, red eyes maybe, and swelling of the hands and feet. It is going towards a Kawasaki disease. Right. So the symptoms are in fever, rash, swollen glands, and everything. Right. So what's the treatment? The treatment is IVIG and aspirin. That's it. If you give a trial of antibiotics, it's not going to improve. Antibiotics will not make things better for this patient. Nothing is going to improve. IVIG and only this aspirin, right? And we have to treat it. If you don't treat, what's going to happen? The problem is inflammation of the heart blood vessels. So it can create problem with the heart. So we have to be fast. And we have to do the hospital referral, obviously, for the management for the IVIG, right? So we need to send your son to the hospital. And in the hospital, what's going to happen? IVIG and aspirin that will be given. Monitoring will be done by doing the echo. And we might consider referring your son to the specialist as well, right? So what else? Like giving the supportive care, giving fluids, making sure the child is not having fever, giving time to time the paracetamol as well. And that's it. And warning signs, always follow up and warning sign. For now, we are sending the child to the hospital. So follow up is not much there, isn't it? But in terms of a warning sign, what you can do is let the doctor know if your child is being too irritable, having too much of fever or having difficulty in breathing, let the doctor know, right? So that's something that you can mention here. And is my child going to recover completely? So that might be a question from the parent side. Is my child going to recover properly, fully? I mean, yes. If you're doing the proper care, yes, most of the children, they recover completely and they usually don't have any long-term issues as well. So that's how you can do the counseling of Kawasaki. So Kawasaki versus scarlet fever, I think you are able to find the differentiating features now. So that is what we have in Kawasaki. All right. Okay. Next, we have got antenatal checkup. Antenatal checkup. Uh, the FY2 in GP surgery, Miss Tracy, she is 26, has come for the checkup. Talk to her and assess her and manage. Sometimes what they do, the they have given another thing in the question, maybe sometimes ultrasound showing 12 weeks gestation, and this ultrasound was done 2 weeks ago. right? So ultrasound was done 2 weeks ago, which shows 12 weeks gestation, and you are quite in GP surgery, and patient has come for the checkup. All right. So you know from the question that she's pregnant, so go and do the antenatal checkup. Let's go and do it. How can I help? I'm here for my reports. Sometimes this is how the things start. Reports of ultrasound scan. So yes, I've got the report with me. Could you please confirm the age of gestation, the pregnancy? Yes, it's 14 weeks. How was it confirmed? It was a pregnancy test at home. Using any contraception? No. Any scans before? Yes, I've done one scan only. How was your pregnancy so far? Everything is going well. Any complication? No. Any symptoms at the moment? No. So everything is going well for her. She's here for a routine checkup and she wants to know about the ultrasound report. And ultrasound is showing 12 weeks gestation because ultrasound was done 2 weeks ago and she's saying I'm 14 weeks pregnant. So everything looks okay. Is it your first pregnancy? Have you done any previous scan before? Have you attended all your antenatal visits and all? Do you have any symptoms at the moment? So you can ask all those questions. Now, what else you can ask? You can ask symptoms for first trimester as well. So you can ask for any nausea, vomiting, any tummy pain, any breast tenderness, any vaginal bleeding, spotting, if the patient has got these things or not. So you can cover these things very quickly as well. All right. You can do ICE as well. Try finding it out if there are specific questions this patient has got. Right. Then you can go for quick past personal social history as well, past medical history. If there's any medical condition, if you've got any medication you've been taking, any supplements, folic acid are you taking or not, any allergy if you have got, isn't it? Any family history of any medical problems, lifestyle. Now, the problem is when you start about the lifestyle, what she said is, do you smoke? Yes, I do smoke. I smoke 15 cigarettes per day. She's pregnant, smoking 15 cigarettes. Do you drink alcohol? Yes, a bottle or 2 bottles of wine per week. Okay. Any recreational drugs? Yes, I smoke cannabis 3-4 times a week. And who do you live with? I live alone. Any partner? No, I'm single. Even if you take a bit of history here, like whom do you live with? The patient lives alone. She's pregnant. So when you try finding it out who's the biological father, then she doesn't know about it, right? She's sexually active, but she's single. There's no regular partner this patient has got. So when you get this history, maybe you try asking some questions about STI as well. If there's any vaginal discharge this patient has got, any fever this patient has got, any nausea, vomiting, any redness, hotness, any ulceration, anything in the private area this patient has got or not. So these are the questions I definitely want you to ask. Right, any fever, nausea, vomiting have already covered. Any redness, hotness in the private area, any UTI signs, symptoms you can ask as well, right? So all these things are negative though, but what we got, smoking is positive, alcohol is positive, patient is taking recreational drugs as well. So all these things are really tricky, right? So the thing is in the question, so you have been given the ultrasound. They also give you some other things as well in the question. They say that blood tests, it's normal, and also urine test, it says no bugs found. So these are the tests reports that has been given to you in the question only, and she has come to know about the results. So now you'll explain that we did the things, that we did the blood test, everything looks normal. We did your urine test as well, and there are no signs of an infection, right? And then what we did the ultrasound scan, the baby is doing well at 12 weeks, and you are 14 weeks pregnant now, so it is definitely making sense. Now the problem is this smoking, cannabis, and alcohol, right? Now, what you need to do is you need to counsel this patient. This is a counseling scenario, counseling for smoking, counseling for alcohol, counseling for drugs as well. If patient continue doing the smoking, what it can lead to? That's the thing. So smoking can lead to complication like premature birth, low birth weight, and breathing problem in the baby. Cannabis can create problem with the baby's brain development, any neurodevelopmental issues the child might have, isn't it? Drinking alcohol can cause fetal alcohol syndrome, leading to the developmental issues as well. Right. So what we advise this patient, we have to advise this patient to stop drinking alcohol, stop smoking, and stop taking this cannabis. And we have got lots of programs, and we can refer the patient to those programs as well. And we have to keep monitoring this health of this patient, and we have to keep monitoring and doing the investigations at the regular intervals. Yeah, that's fine. But the main thing here is, see, young girl, okay, she's 26. no partner, drinking, smoking, and taking drugs. Is there anything else you feel that we should be adding? Uh, Please inform safeguarding team if you feel it's there is some health risk to the baby, right? I mean, see, who we are FY2, and I don't want you to take the final decision in these kinds of cases. Before you send the patient home, I mean, first of all, I don't know when you start counseling the patient about smoking, alcohol, and drugs, whether she's going to agree with you or not, right? If she's agreeing, that's one thing. If she's not agreeing, or even if she's agreeing as well, I don't want to discharge this patient without involving my seniors. So I would like to involve the seniors as well, because it might be a safeguarding issues as well. During the conversation with this patient, you have to see if you are getting lots of non-verbal cues or not. That is very, very important. It might be a scenario, it might be a scenario of domestic violence as well. You have to see if all these answers are coming very frequent, I mean, very quickly, or you have to dig into it to get the information from her. So you may be having lots of non-verbal cues as well. Somebody is pregnant, drinking alcohol, smoking, and drugs. Not a straightforward scenario. Look for non-verbal cues. It might be domestic violence scenario. Who else is there in the family? Try digging into it. And before you close the station, make sure you involve the senior. I mean, see, if you feel like, yes, there are more risks there, involve the safeguarding team, involve social service. But if nothing is very clearly given to you, not any non-verbal cues as well, what to do in that case? I'll still involve my senior. I'll still be in a safe position. I won't discharge my patient on my own. I would like to have my seniors in the picture as well. All right. Okay, let's go with the next one. Blood test report. It was a hepatitis B. Have a discussion. Let's see. You are in medicine. Patient is 47, has come to the hospital to discuss the blood test reports. Yeah. So talk to the patient, assess and management. Yeah. Patient blood results ready, and the results are ALT. If you see, it's a bit on the higher side. ALP is in the normal side. HbSAg is positive. Yeah. And bilirubin is kind of normal. Right. How can I help you? I'm here for my blood test report. Acknowledge it. I can see you are here for your blood test report. I've got the blood test reports with me. Before I explain it to you further, so that before I explain you, I would like to ask you some questions so I can answer your queries in a much better way. Right. Yes, doctor, please go ahead. So first of all, could you please tell me why did you underwent these blood tests in the first place? The reason is, doctor, I was feeling sick. Okay, feeling sick. So, just do a bit of OD para. For how long you been sick? Is it getting worse? Did you vomit? If vomiting, were you in dehydration or not? Ask those questions as well, right? I was feeling tired. Anything else? Okay, feeling tired as well. So tiredness started when? It started with the sickness only. All right, any other symptom? Like what? So now we understand from the question itself that it is hepatitis, isn't it? And it is HbSAg positive. It is hepatitis B. That we understood. So now what you need to do? You need to ask questions related to hepatitis. So start asking any yellow discoloration of the body, any problem with the stool or urine color, any itching, weight loss, appetite loss, diarrhea, fever flu-like symptoms. Ask all those questions and see if there is any yes or no. Right? Now, hepatitis B, how it spreads. Number one, I would like you to take sexual history properly, multiple sexual partner, unprotected sex. Number two, recreational drugs, sharing needles. Number three, maybe tattoo, piercing. All those things are very, very important, isn't it? And maybe there is any blood transfusion, but they are very clear. Our blood is very good. So any blood transfusion outside the UK, that's something that you can ask, right? So all those questions you need to cover, yeah? So quick past personal psychosocial history. Have you had any blood transfusion before? Maybe blood transfusion, if you were to be very clear here, outside the UK. That's something you can ask. Yeah. Any smoking, drinking alcohol is very important, because when you have got any trouble with your liver, your liver is weak. So even maybe a pint of beer on weekends is not a good idea, isn't it? You should be stopping your alcohol completely. So asking about alcohol, diet, if diet is good or not. Yeah. The main thing I said, what you need to do is recreational drugs, sexual history, tattoo, piercing. So ask those questions. And this patient says, yes, I'm sexually active. I just broke up with my partner and he was cheating and you practice safe sex. Usually the answer is no, doctor, no. So this might be the positive history. Sometimes you might get the drug history positive, sharing needles. I don't know, but you'll get something. So you'll have something to blame. This is the reason maybe in your case. All right. So do eyes, any idea you have got? Not doctor, tell me. So your blood test shows that you've been tested positive for hepatitis B. This means you have been exposed to this hepatitis B virus. All right. So let's interpret the result, because when the task is explain the blood test report, then I would like you to explain all the blood test report properly to the patient. Then only it's going to make sense. So HBsAg positive means what? That this means you have an active hepatitis B infection. That's one. Number two, ALT is raised. This suggests you have got some level of swelling in your liver and normal ALP in bilirubin. So no sign of liver obstruction or severe liver damage at this stage. So normal ALP. So there is no obstruction here, right? So that's why if you see the stool and urine color might be okay, normal as well. Yeah. Now, the further test to determine if the infection is acute or chronic, because the treatment of acute is different, the treatment of chronic is slightly different as well. So, what you will be doing, first of all, we need to do more investigation here. Now you got a bit of idea, it's hepatitis B, so go a bit more in detailing. You check for IgM and IgG. IgM, IgG. G is long term, M is the short term recent infection. So IgM positive is for recent and IgG is for long term infection, chronic. I'll do HBeAg, hepatitis E antigen. So that indicates high viral activity and infectivity. And we will do hepatitis B DNA that measures the amount of virus in the blood. So these are the further investigation we will be doing. So what I'm going to do after HBsAg, first of all, I'll check for this infection, like for how long you've been having it. So I'll check for antibodies. I'll check for IgM and IgG. IgM positive, meaning recent infection. IgG positive, it's a chronic infection. Then I'll check for hepatitis HBeAg. That will tell us high viral activity, infectivity, how infective you are at the moment. And then we will be checking HBV DNA, meaning the measures the amount of virus in your blood. So these are things we'll check. If it is acute hepatitis, what's the treatment? To be honest, nothing much you can do. So in most cases, the immune system clears the infection within 6 months. What is the treatment? Rest, rest, and rest. Avoiding alcohol and good diet. I mean, not very, I mean, it's a healthy diet you need to take, isn't it? And don't go for fast food, oily food, and all. Very, very bland food you need to be taking. Yeah. Avoid sharing personal items, razor, toothbrushes, and all those things, and notify the close contacts so they can be tested and we can vaccinate them accordingly. If it is chronic infection, IgG positive, more than 6 months of history that we have got. So lifelong follow-up is required, obviously. But in this case, you might be going for antiviral treatment and doing the regular checkups or ultrasound for your liver as well. Yeah. Any hepatitis B case, what you will be doing, HIV screening is mandatory and it is a notifiable disease as well, right? So that's the thing. In terms of treatment, I mean, it's a simply lifestyle advices, and whatever symptom patient has got, you'll be able to treat the symptoms. All right, follow-up and warning sign. Obviously, repeat the test 6 months to check the virus is still present, and we can refer you to the liver specialist as well. So, I mean, that's what we have got for hepatitis B blood test reports. All right. Okay. Vulva cancer. So you are in surgery and patient is a 65-year-old female. She's come to you because she has got a lump in her private area. Talk to her, assess her, and address her concern. Okay, so before we go into the station, so vulva cancer, one of the predisposing factors, a pre-malignant condition I would like to talk about is lichen sclerosis. If a patient has got lichen sclerosis, they are prone to get vulva cancer as well. All right. So I have put the things separately here. Let me explain these things a bit more in detail, and then I'll tell you what kind of scenario you might be getting in the exams. So this is a picture for lichen sclerosis. And when you see a lump and all, so this is a picture of cancer, vulva cancer. So what is lichen sclerosis and cancer? So it's a chronic inflammatory skin condition affecting the genital skin, and usually you will see it happens in post-menopausal women. Yeah. Is it malignant or benign? It's benign, but it can transform into malignancy. And what is cancer? Cancer is obviously it's a malignant tumor of the skin, vulva skin. And again, you will see it in an elderly female. Is it malignant? Of course, it is malignant. Yeah. Now the features. So why we get lichen sclerosis? It is known to be autoimmune condition. Known to be autoimmune. But what is the cause of vulva cancer? So number one is lichen sclerosis only. The patient had lichen sclerosis, they are prone to get vulva cancer. That's one. Second is HPV infection. And if the patient is immunosuppressed, so these are the other risk factors. All right. So associations, obviously, as it is autoimmune condition, so other autoimmune conditions are there. Yeah. Symptoms. Symptoms are going to be what? I mean, severe or persistent symptoms that you will see. Which symptom we are talking about? The pain often during intercourse or even urination, burning sensation, pain, that's going to be there. And usually what you will see in lichen sclerosis, you'll have the narrowing of vaginal opening. That's the main thing that you will see in lichen sclerosis. Here also, if you see, there is a narrowing of vaginal area. I mean, that's the main thing that you will see, right? The narrowing of vaginal opening that you will see in sclerosis. Yeah. Okay, what else? Here, vulva cancer, obviously, patient initially may not have any symptom, but then later on, obviously, the patient might be having all cancer symptoms, weight loss, appetite loss, anemia symptoms, and lumps and bumps. That's the main thing. Ulceration, lumps and bumps, which is getting worse, isn't it? Lump, ulceration, bleeding, all those things, ulcerated or cauliflower-like growth you might see. Yeah. LS, lichen sclerosis, symmetrical and focal lesion, this one. And so irregular, and there might be some bleeding as well. Now, the diagnosis. How you diagnose lichen sclerosis is just when you'll see the picture, I think you'll be able to make the diagnosis. Even for vulval cancer, what's happening is obviously you have to investigate it further. You have to do the biopsy, then only you'll be able to make the diagnosis. Yeah. What's the management of lichen sclerosis? You can give topical corticosteroid and that should be fine. Whereas in vulva cancer, you have to make 2 weeks urgent referral to oncology team and then they will be able to see how it is managed. I mean, it's a team of doctors, the MDT team will sit and then only we'll be able to decide. Lichen sclerosis, so it's chronic and the 5 times lifetime risk of progressing into SCC, squamous cell carcinoma. And here the risk, I mean, the treatment, the prognosis depends on the size, I mean, the stage and also the lymph nodes, if it has spread or not. That's the main thing, right? Okay, so why we had this discussion on lichen sclerosis and vulva cancer? Let's see. So your patient is 65, has got lump in the private area. Okay, elaborate. How can I help you? I've got a lump in the private area in the vulva and it has been there for the last few weeks and what I feel it's getting worse. All right, getting worse means what? Like, is it getting worse? Like, is it increasing in size? And then you can ask other questions like, any itching, any pain, any bleeding, any discharge, any burning sensation, UTI questions, any rash, and obviously patients, any patient more than 50, 55, you need to be worried about cancer, any cancer. So what you're gonna do, you'll be asking for weight loss, appetite loss, anemia symptoms like tiredness, shortness of breath, dizziness, palpitations, and lumps and bumps anywhere else in the body. So all those questions you are supposed to ask here. All right, maybe you can ask if the patient was vaccinated for HPV or not. So that's very, very important as well. Yeah. And are you sexually active? So you can ask those things as well. No, my husband died a few years ago. All those things and female patients, so maybe you can cover EPP questions as well. Pregnancy, patient had, so that's not very important. Periods, I don't think so. She had the periods, she's 65, and maybe previous cervical screening and all, if it was okay or not. So that's something you can ask. Now what you do, you go for past medical lifestyle, psychosocial history, whom you are living with, because if you're dealing with cancer, you need to know who is there in the family as well. So you need to have that support system. That's really important. Yeah. Another thing in the past medical history we got, patient had a history of lichen sclerosis. That's good. So when you get it, so it is taking you towards that cancer. Okay, it might be vulva cancer, isn't it? So patient gave the history. Yes, I was diagnosed a few years ago. Patient said, I was diagnosed a few years ago with lichen sclerosis. And patient said, how was it treated? Patient said, I was given a medicine. I was given a medication to apply. Was given a medication to apply as well. I was given a cream. So patient says, how was it treated? I was given a cream and I was applying it, and then it was actually fine. Now what you have to do, I would like to do blood test, urine test, and maybe swab. Then what you have to do, you have to do a nice ICE actually, idea, concern, expectation. So, like whenever we are suspecting cancer, we need to put all things together. Patient has to get the idea that we are worried about cancer. As a doctor, I don't want to say the word cancer first. The cancer word should be there in the conversation, but it is always a good idea if it comes from the patient side. You have to say to the patient, okay, you have got this symptom, you have got this symptom, you have got this symptom. So you have got a lump which is getting worse. You may be having weight loss or appetite loss, and you had a history of lichen sclerosis a few years ago. So do you have any idea what it can be? So try putting all the things in a proper way, right? And obviously, what we have to do is when we're suspecting vulva cancer, so we need to arrange for 2 weeks urgent referral. Patient will be seen by the specialist within 2 weeks' time, and the specialist will be able to do further investigations. Right. So then we will see how it's gonna be, what it's gonna be. Right, so you will be giving a possibility of cancer. Now this patient is asking, doctor, I have been given the cream for the treatment of lichen sclerosis last time. What do you think? Can I continue with the same cream? So first of all, what's the treatment for this lichen sclerosis? Lichen sclerosis treatment. So topical steroid, uh, that is what we give. Emollients for moisturizing. Avoid irritants, I mean no soap and all, and regular follow-up. That's what we do. And biopsy if suspicion and not improving, because then it might be going towards vulva cancer, right? But in this case, the one I've just discussed, patient had a history of lichen sclerosis a few years ago, now presenting with a mass growth. So we are thinking about vulva cancer only. Can I use the same steroid cream? Answer is no, not really. Not really, not really. So what we're going to do, we're going to refer you to the specialist and they will be able to tell you more about your treatment plan. Right. Now the patient is taking steroid. Do we need to ask about the side effects of the steroid? You can, but it is a topical steroid, so patient may not have much of the side effects and all, because if the patient is taking systemic steroid, patient will have lots and lots of side effects, right? But here it was a topical one. But can I continue? That was the main concern your patient had. Can I continue? The answer is not really. Not really. Not really. Yeah. So that is what we have in vulva cancer. All right. Okay. So next one I'm going to discuss is atrophic vaginitis. Atrophic vaginitis. So you have FI2 in GP surgery, and the patient is 53, had made an urgent appointment. Talk to her, assess her, manage her, and address her concern. All right, so how can I help? Doctor, I'm a bit embarrassed to talk. Whenever it comes to the private area, the patient's not going to be very much straightforward. So they might be a bit concerned in the beginning. So it might take a bit of time, maybe a minute, just to make them comfortable, and then they will start talking to you. All right, so how can I help? So I'm embarrassed because I have got this itching and soreness for the last few days in my private area. I'm embarrassed. I've got itching and soreness. All right. Could you please tell me a bit more about it? Doctor, what do you want to know? So do you have got any redness, any dryness, any discharge coming, any pain, any burning sensation in passing urine? So I'll just cover the UTI part as well, right? So then obviously I'll ask if there is any discharge coming or not, patient is sexually active or not, patient is 53, so I'll ask about the menopause, if patient has got the periods or not. So any female patient, just remember these PP questions: periods, pregnancy, pills, any contraceptive pills, and pap smear. So make sure you cover these questions. I'm not saying any female you have to ask these 4P. I'm just saying think these questions in your mind. Are they important or not? Now I start saying, I have started saying 5P. Fifth P is partner. See if the patient is sexually active, having partners or not. So that's really, really important. Right. So that's something that you can ask all those questions. I mean, any discharge, bleeding coming, any burning sensation, any dryness, redness, all those questions. So this patient says, I'm using soap 4 times a day. I mean, when somebody has itching and all, they think, okay, I have to clean it even maybe more often. And the patient's saying, I'm using soap maybe 4 times a day. That could be one of the risk factor, right? So what you do, quickly pass personal and social history you will take. And last period, the patient had at 43. That was quite early. So you can see whether there was a reason for early menopause. That's something we can see. I mean, maybe patient had a surgery, oophorectomy, hysterectomy, so that could be one of the reason as well. Maybe patient had a treatment for any anything like say any cancer or so. So that is very, very important as well. Yeah. Then quickly, I would like to do general physical examination, vitals and the examination of the area, the private part, and would like to send some routine investigation like full blood count and maybe urine test. That's something that you can do. So what we would like to do, I would like to do general physical examination, would like to check for your vitals and the examination of the private area. I would like to send for routine investigation and urine test. If the patient has got any discharge coming, so maybe we'll take swab sample as well. That's what you do, right? And the diagnosis is the patient has got atrophic vaginitis. The reason patient has got this itching and soreness. My patient is 53, so my advice would be one more thing I would like you to do is please ask for loss of weight, loss of appetite, and if patient has got any tiredness, any dizziness, any palpitation, any lumps and bumps. So these are the questions also I would like you to cover quickly in the history. All right. So atrophic vaginitis, the symptoms will be soreness, itching, and discomfort when you are passing urine. Dysuria you will be having. Treatment is not much actually. The treatment is first of all, you have to get rid of the causative agent, which is soap. Right. So avoid using soap perfumed products in or around your vagina. Use a simple, gentle, unperfumed emollients. That's the main thing. And wear comfortable cotton underwears and drink plenty of water. Right. The treatment is a moisturizer. That's the main thing because itching is there because of dryness only. So you need to put some more and more of moisturizer. That's the main thing. And if the symptom persists, we can consider giving low dose estrogen, vaginal estrogen as well. So that will be quite helpful, right? And give the warning sign if the symptoms are not improving, it's getting worse, so you started having any bleeding or there is persisting pain, make sure you come back to us. Make sure you come back to us. Right. Now and then, if you see, I've written something about the vaginal discharge as well. So just have to be very careful that if something is positive in the history. I mean, if patients have got white and lumpy discharge, so whitish cottage cheese kind of discharge. So we are thinking about thrush, yellow-green discharge, so it might be a sexually transmitted infection. And if patients say dry, itchy vagina and all, so that is hormonal change after menopause. That's what we are thinking here. That's what it is. That is atrophic vaginitis. And if it is itchy, sore skin around your vagina and other parts of the body, could be eczema, lichen planus as well. So that's just a table summarizing everything. But here, the main thing was itching, soreness. It was going towards atrophic vaginitis. All right. Now the glandular fever, infectious mononucleosis. You are FY2 in GP surgery. Patient is 22 years of age, has come in with the sore throat. It was 10 days ago. Patient came to us 10 days ago and he was febrile, but there was no cough. Actually, they're trying to give you Centaur criteria. Centaur criteria. So there was no cough, patient was febrile, and on examination, what we found, patient has got painful cervical lymphadenopathy, and patient was prescribed phenoxymethylpenicillin. Now talk to the patient, assess the patient, and discuss the management and address the patient's concern. So it's more of a counseling scenario. First of all, lots has been given to you in the question that patient had sore throat. It was 10 days ago. Patient was febrile as well. There was no cough. Patient was having painful cervical lymphadenopathy, and patient was given phenoxymethylpenicillin. Go and talk to the patient. So what do? You start, how can I help? And patient is like, I'm having sore throat and it's not getting better. All right. So could you please tell me a bit more about it? I mean, is it getting worse? It is getting better? Anything makes it worse? Anything makes it better? What kind of treatment you were given? Were you compliant with the treatment? Do you think the treatment like what we gave you, the antibiotics, were they improving your symptoms or not? Are you able to eat or drink well? Are you able to swallow food? Are you able to eat properly or not? Right? So all those questions you need to ask. Whatever given in the question, so you can use a lot of information and ask a lot of things from this patient. All right. And then yes, any rash, feeling tired, tummy pain, that's very important. See, if it is normal bacterial infection, if it was normal bacterial infection, this phenoxymethylpenicillin would have corrected it. But the patient is not feeling better. So it could be infectious mononucleosis as well. Epstein-Barr virus is the main reason here, isn't it? So now, when we're thinking about infectious mononucleosis, EBV, I would like you to ask for tummy pain as well, because the high chances are there patient might have a splenic rupture in glandular fever or infectious mononucleosis. So that's why tummy pain. I mean, eating, drinking, loss of weight, appetite, night sweats, all those questions for fever and all you can cover, right? So a lot of things you got from the question itself. Sore throat, elaborate sore throat. Febrile, what are you taking? Is it managed or not? Do you have any cough now? Are you able to eat or drink well? Are you able to eat food properly or not? Yeah. And then tummy pain for splenic rupture and all, I would like to definitely cover, right? Then what you will be doing, sexual history you can take, because EBV, what is it? It's also known as kissing disease as well, right? So quick past personal and psychosocial history you will be taking. Any recent contact, someone with a sore throat, similar thing. Now, the thing is, what is most important? Are you physically active or not? Sometimes this patient will tell you, I'm a rugby player here itself. If not, this patient will bring this point in the later part of the station. How? I'll tell you. Then you'll say, I would like to do general physical examination, vitals, ENT, tummy examination, and lymph node examination as well, right? See, why I said about this tummy examination here, because I would like to check for the spleen as well. That's main important. Lymph node, the patient has already got it, right? So full blood count, ESR, CRP, liver function, throat swab you will take. Now your dear examiner gave you some finding that bilateral tonsillar exudates and the temperature is 38.5. When you take history, patient will say, I don't have fever now because he's on paracetamol, right? But then temperature 38.5, tonsillar exudates. So lots of examination findings are given to you in the question. A lot of examination findings are given to you by the examiner in the later part of the station, right? So now what you have told me, the examination investigation we have done, we feel you have got glandular fever. It's caused by a virus, Epstein-Barr virus, right? So it's common in people of your age and often leads to this. Sore throat that doesn't respond to antibiotics. That's one thing. This patient has been having sore throat for last 10 days and we've been given phenoxymethylpenicillin. Patient is not improving. What it is, it's EBV, glandular fever. Patient has got swollen lymph nodes, patient feel fatigue, tiredness, and maybe patient has got enlarged spleen as well, right? What you have to do, it's a self-limiting thing. It's a self-limiting thing, nothing much you can do, but the recovery can take few weeks actually. It's been 10 days, it might take another 10 days or so, and then you will feel better. What's the treatment? No need for antibiotics actually. So treatment is rest, avoid overexertion, paracetamol, and hydration. Water, water, water. Maybe if you've got a problem like tonsillar exudates and also salt water gargles and all might be helpful. Now the thing is, patient should be avoiding contact sport for 4 to 6 weeks. That's the main thing because it can lead to splenic rupture. That's the main thing, right? Avoid further antibiotics unless a secondary infection is confirmed because patient already done the course. You don't need to give any further, antibiotics as well. If a maculopapular rash develops after penicillin, it's supposed diagnosis of mononucleosis. Supports, but I think whatever we got, patient is not improving. It's enough to make the diagnosis of glandular fever. Safety netting, obviously, always what you have to do is follow up. Follow up is and warning sign would be what in this case. Breathing or swelling becomes difficult, come back to us. Severe abdominal pain because it could be because of splenic rupture, and high fever, neck swelling is getting worse, rash or persistent symptoms beyond 3 weeks. So make sure you come back to us. So we're going to review your bloods maybe in a week time, 3 to 5 days, routine follow-up. And if the patient says, I want a fit note or so, there is no harm in giving one to the patient. We know that for first week, you can self-certify, isn't it? You can self-certify, but after that, after 1 week, you have to write a note. Fine, that we can give. Now, when you do proper eyes and when you ask the expectation question to this patient, he says in the end, doctor, next week I am participating in a rugby tournament. Is it okay if I go ahead? The answer is no, no. You should be avoiding contact sport for at least 4 to 6 weeks because it can lead to severe tummy pain because of splenic rupture. So that was the scenario for glandular fever, infectious mononucleosis, or Epstein-Barr virus. All right. Now the next one. Hyperthyroidism, worried about menopause. Your FI2 in GP surgery, patient is Anna, 40 years, has come to you with the tremors and hot flushes. And it's more of a counseling station because the reports have been given to you. The result shows that TSH is low and T3 is high. I'm not sure about T4, so they might have given T4 as well, but I think TSH low, I've got enough finding. I know what it is. And the patient presenting complaint, tremors, hot flushes, and I've got a female patient. So we understand what exactly it is, right? Patient is a bit anxious as well in the scenario, and the patient started, I'm having these tremors and hot flushes. Okay, tell me more. Tell me more about your tremors. Tell me more about hot flushes. The tremors, are they getting worse? For how long you've been having this tremor? Is it like when you do something, or if it is present on rest also, right? So all those questions you can ask. And then I would like you to ask some other questions for hyperthyroidism as well, like sweating, hot flushes there, like eating, how's your eating? Sometimes you'll see patient is losing weight despite eating too much, isn't it? If the patient is losing weight or not, right? Patient has got maybe diarrhea or not. So all those questions you need to ask. Ask about the periods as well. Ask about any sleeping problem this patient has got, right? So all these questions you need to ask. So elaborate tremors, elaborate hot flushes, and please do ask other symptoms of hyperthyroidism. Right. Okay, and this patient says, I've lost some weight as well. That's okay. And when you ask for the periods, here the patient gave you something interesting. When was your last menstrual period? Doctor, a week ago. And if your periods are regular or not, patient is like, not really. Over the last 2-3 months, they have become irregular. And the last month, it came actually in 36 days. So your patient is 40 and periods are becoming irregular. So later on when we did eyes, okay, what is your idea? What do you think you might be having? The patient is worried if I have menopause or not. I know that, I mean, I'm 40, I know, but then I know in the females, when they are getting old, they will go into menopause. And that is the time when their periods become irregular. So I just want to know if that's the case that's the case with me as well. All right. So what you did, you elaborated tremors, hot flushes, asking other questions for hyperthyroidism as well, and quick past personal history, and you do eyes and patient is worried about menopause. I was wondering if this could be early menopause. The irregular periods and hot flushes got me thinking about it. You will acknowledge, I can see you are concerned, and that's a reasonable one. At 40, it's a bit early for the natural menopause, though not impossible. However, your symptoms and blood results suggest your thyroid is playing a big role here. And the problem with the periods can be there because of hyperthyroidism, isn't it? So let's talk about it. I would like to do a general physical examination, your vitals, your thyroid examination, and maybe eye examination as well, because eye is affected in thyroid, right? And we have already done some blood tests, and let's talk about it. The blood test is like we have found that your TSH is low and your T3 is high. It means it suggests that you have an overactive thyroid, also known as hyperthyroidism. So now what you want to do? Further tests, I mean, we can do this TFT, thyroid function test at regular interval, and after like 3 to 6 months, we can do thyroid autoantibodies, ECG, just to make sure heart is okay because of your hot flushes or palpitations, right? And we may be able to do thyroid ultrasound scan as well. What is the treatment? Hyperthyroidism, you need to reduce the level of T3. So what you do, anti-thyroid medication, carbimazole, right? So and in here, any female, PPP question. I'm not saying you have to ask these 5P questions to every patient. But what I want you to do is just screen through these PP questions in your head. Periods, very important here. Pap smear may not be. And pregnancy, pills, or partner. So this is history very important. So why I'm saying partner is important. So if the patient has got any plan for having kids, she is 40. Maybe she's planning for kids. Then in that case, we may not be able to give carbimazole. We might be going for propylthiouracil. So that's something that you can do. And whenever you give carbimazole, you have to do a bit of counseling as well. Carbimazole is not a very safe medication. It can cause agranulocytosis as well. In that case, if patient gets, agranulocytosis, you might be admitting and treating the patient, isn't it? So you need to give some warning signs as well to this patient if you're planning to start this patient on carbimazole, right? And then the beta blocker can be given for the treatment of tremors or palpitations. And if you maybe we can make a referral to the endocrinologist as well, right? And every station, what is our main aim? Please always come for the follow-up. That's very important. Every 3 to 6 months, you will be doing third function test as well, right? And seek urgent care if you experience a chest pain, severe palpitation, fainting, or you can give the warning sign for carbimazole as well. I mean, you have got repeated chest infections, for example, any tummy pain, because it can lead to pancreatitis and all, right? Can lead to jaundice as well. If that's the case, make sure you come back to the hospital. Right, so that's something that we can do. Now, the patient has come to the GP. Can GP start the patient on carbimazole? Yes. In normal circumstances, yes, we can start the patient on carbimazole. So GP can start. If needed, maybe, and if patient is not improving, maybe we can refer it the patient to the specialist as well. So this is what we have got in hyperthyroidism, where the patient is worried about menopause. All right. Okay, another one. Contact dermatitis. Your FY2 in GP surgery, the patient is a young guy, 26 years of age, and patient has got a rash on the hand. Talk to the patient, assess and discuss the management with the patient. Yeah. So, how can I help? The patient says, I've got rash on my hand. I've got rash. So what you do? Again, you do OD para, elaborate about the rash, see the rash is getting worse, rash is getting better, what makes it worse, what makes it feel better, is it only in the hand, is it anywhere else or not, if there is any redness, any dryness, any itching, any ulceration, any bleeding, all those questions, I mean, you have to ask. Yeah. So the patient is saying it started as redness or dryness and now it's itchy and it's very irritated as well. And is it spreading anywhere? No, it's just in my hand actually. So is it itchy, painful, burning? All those things you can ask, right? So, like what makes it worse? So this patient gives you a history that actually, number one, I've got latex allergy. I have got latex allergy. And initially, when I used to wear latex gloves, I used to have it, but now I started wearing non-latex gloves and everything was going okay. And where he's been working, this patient is working in a healthcare department where he said, I have to deal with the cleaning chemicals. That's the main thing. But now what happened is he was using non-latex gloves. Everything was going okay. But then supervisor said to this patient, we don't have non-latex gloves anymore. And then the healthcare area, I mean, where he was working, they started having only latex gloves. But then what he started doing, he knew that I'm allergic to latex. He started managing all the cleaning and everything without wearing gloves. So he got the allergy because of the chemicals as well. So he's allergic to latex and he's allergic to chemicals as well. So he started without gloves only. So he's not using the gloves. Then when we asked, did you talk to your supervisor about it? And he said, no, I haven't. I haven't. Okay. Then when there is allergy thing, then he'll ask if there's a history of hay fever, eczema, asthma. So I would like you to cover that part as well. Have you tried anything? Yes, I've tried a moisturizer cream, but it is not helping much, right? So that's the thing. So you have to find allergen. And the problem here is latex, but now is a chemical that he is using, right? Did you speak to your employer? The answer is no, right? So do you have any idea what's going on? Do you have any thoughts about what might be causing this rash? I think it's because of the latex gloves or the cleaning chemicals, right? So we understand what is happening here. So we'd like to do like general physical examination, vitals, and your examination of your rash. And this is what we got actually. So this is what we actually got. Contact dermatitis, irritant contact dermatitis. Yeah. So what's the management? Management is first of all avoid triggers. Number one is avoid latex gloves. That's one. But this patient said I'm not wearing them. So and wear protective gloves actually to prevent the contact with the cleaning chemicals. That's the main thing. And I would like you to speak to your supervisor so they'll be able to arrange something which is obviously number one non-latex so that you can wear non-latex gloves when you are doing the cleaning or you're dealing with the chemicals. For the treatment, what we can give, moisturizer, that's one, but he said it's not helping me much, right? But that is like again and again, you have to use it. Or we can give hydrocortisone cream as well, and that should be okay. General advice is wash your hand gentle, soap-free cleanser, avoid scratching, and if there is any sign of infection, make sure you come back to us. So any pain, pus, or any redness, if it's spreading, make sure you come back to us. That's the main thing, right? Follow up, review in 2 weeks if symptoms do not improve, and seek medical help if there's a sign of infection, right? So these are the main things. So whenever you get these kind of station contact dermatitis, you need to find out the reason. The management is obviously you can give emollients, moisturizer, hydrocortisone cream, but you need to find out the main risk factor and you need to manage it to get more marks. All right. Another one. Gastric carcinoma. So your FI2 in GP surgery, patient is 63, came with the complaint of indigestion, right? Talk to the patient, assess and discuss the management and address the patient's concern. How can I help? I've got indigestion. Tell me more again. So what do? You do proper OD para here? Tell me more. I feel burning sensation in my tummy after eating. I feel a burning sensation in my tummy after eating. Okay. Sometimes patients is after eating spicy or sometimes like just after eating I'm having it. And for how long? It's 3 months. Have you done anything? Because sometimes you'll see patient might have taken over-the-counter medication to make feel to feel better, isn't it? So that's something we're trying to figure out here. So the patient has got indigestion. The patient has done anything to make it better. Anything else like what? So whenever we have got an elderly patient, the main thing that comes in our mind is gonna be what? Is weight loss, appetite loss. So cancer symptoms, that's what you need to ask. Loss of weight, loss of appetite, palpitation, dizziness, tiredness, lumps and bumps anywhere else in the body. So that is something that you need to ask for any cancer. Indigestion and the cancer symptom. And what we got is half a stone. Patient has lost half a stone in last 3 months and it was not intentional. So half a stone, one stone is a 6.35 kg is one stone. So if I say half a stone means what? It is roughly 3 kg. Is it significant? Yes, it is significant. If the patient was trying to lose weight, not really. Patient wasn't trying to lose weight. So that's very, very important here, right? Now, I got something like it. Look, it's going towards cancer. Now, which cancer? So ask if there's any problem in like swallowing, any problem with the like dysphagia if there is any. And for the gastric, I'll ask if there is any melena or not, right? Any change in the stool or urine color? I mean, that's the change in the color of the stool. Melena, any blood, bloating, tummy pain, bowel habits, difficulty in swallowing. All those questions I'm gonna ask, right? And if there is any dysphagia, I mean, any like esophageal problem, then patient will have trouble in eating, and then we have nausea, vomiting as well. So that's what I have asked here as well. Quick past personal history as well. Now, whenever you are thinking about any cancer in the GI tract, the main risk factor that you need to look for is smoking. You need to look for diet, processed meat if person is taking, and then another one is the family history or present or not, right? Smoking, diet, processed meat, and a family history. Please make sure you don't miss out on these three things for sure, right? So, yeah, my father had colon cancer, so that's very important finding that you have got, right? Smoking and diet, processed meat, if you are using or not, that's very important. Yeah, I would like to do general physical examination, vitals, abdominal examination, and neck lymph node examination. So, varicose lymph node, left or right side, which one? Left side. So make sure you mention it specifically. So you sometimes when you mention very generally, I would like to do the examination, you may get all the findings. But sometimes what you have to do, you have to specify what exactly you're looking for. When you say that, then only it's gonna go ahead and you will get more findings, right? So what you have told that you have problem in the stomach, and I would like you to do a proper eyes that you have got this indigestion that's going there for last 3 months and it's getting worse. Moreover, you mentioned that you're losing weight as well. It's been 3 kg roughly that you have lost in the last 3 months, and it was not intentional at all. And you also mentioned your father had colon cancer. So I just want to know, do you have any idea what's going on with you? Are you concerned about anything in particular? And I think the patient is going to say, I'm worried about cancer. Because see, if somebody is having the problem for the last 3 months, losing weight, father having history of cancer, do you think they have Googled it? I'm sure they have. So the Google is going to say what? There's a possibility of cancer. So that conversation has to be there. I mean, that conversation is coming from the patient side, that's always better, right? So do proper eyes and get things from the patient, then it's going to be 2 weeks urgent referral, 2 weeks. Patient will be seen by the specialist within 2 weeks time. Now you can do the blood test and yeah, that's the only thing that you can do, and then you'll be referring the patient in 2 weeks time. Patient will be seen by the specialist and they'll be able to do further investigation. Which further investigation? Endoscopy. So it's a flexible tube, we're going to pass through your mouth to your gullet, and then we'll see your tummy from inside, and if need, we might be able to take a sample and then we'll investigate and we'll see what's happening. Right, but then patient has to wait for some time. So meanwhile, give some advices on the lifestyle, like for example, eat small, frequent meals, avoid processed food, excessive salt, alcohol, stop smoking, all those things that you can mention. And obviously, follow up and warning sign. See, the patient is in GP and you're telling the patient we're suspecting cancer and we'll see you in 2 weeks' time. That's a very tricky thing. So what you have to do here is you will tell the patient, I know you have got a lot of questions. So make sure, I mean, feel free to call us again, feel free to book another appointment, and we'll be seen by the specialist within 2 weeks' time. Now, the thing is, in these 2 weeks, if patient develops any more problem, for example, like you're not able to eat, you're not able to drink, and symptoms are getting worse, what you do, make sure you go to the hospital straight away. So that's something you can give as a part of warning sign as well. In regards to follow-up, you'll be called within 2 weeks' time. That's what you have to do. All right. So that's what we have got in gastric carcinoma. All right. Okay, let's have a discussion on this as well. Sexual performance anxiety. So, you are in a GP surgery. You have got a young man, 19-year-old. You want to discuss about an issue that happened during a sexual encounter. Talk to him, assess him, and address his concern. So, as I said previously as well, so sometime they will give you the presenting complaint in the question that this is the thing we would like to talk about. I mean, that's a presenting complaint. But sometimes they just give very open scenario that the patient has come with some concerns. Right. So that's how it works. So how can I help? The patient is like, I'm in an embarrassing situation during sex and I can't stop thinking about it. So it may take a bit of time as well. Patient is not going to be talking to you straight away, like very openly or so. Patient will be a bit embarrassed. So you have to spend some time, tell the patient, I'm here to help. If you tell me more, if you tell me about what exactly happened, I'll be able to help you out. We are open. We are not judgmental. I'm not here to judge you. I'm here to help you out, right? And feel free to talk to me. And then you ask the patient a bit more detail, and the patient will tell you, I met a girl at a club last weekend. We flirted and she invited me to her hotel room. But when we started, she commented on my penis size, and after that, I couldn't continue. So he got into that stress when the girl said all these things to him. Now, so yes, this must have been very distressing for you. Then you can ask a bit of like, was it the first time? Has it happened before? If he was sexually active or not, and if he was able to do sexual intercourse properly, if he has got any problem with morning erection or not, any pain during sexual intercourse or not, any what exactly the thing, right? So, I mean, Were you able to get the erection initially? Yes, he was able to get the erection. Any pain? There was no pain. So since that event, have you been able to get an erection on your own or any other situation? Yes, when I'm alone, I don't have any problem. Okay. So do you get morning erections? Yes, I do. So there's no loss of libido as well. Have you noticed any change in your libido? No, I still feel the same. Have you experienced any issue with anybody else? But he's like, I haven't had sex since then. Have you been feeling stressed or anxious about it? Yes, I just keep on thinking about this all the time from last few days since it has happened. Now you can ask how it has affected your mood, you enjoying things you used to enjoy before, how's your self-confidence, your self-esteem. So he feels low as well, right? So have you had any sexual intercourse successfully before? No, it was my first time. I'm not usually sexually active, but this is the first time. Okay, when it is first time, so patient or somebody, anybody can have performance anxiety as well. Moreover, if somebody commented like on the penis size and also, it is again very difficult. So there are a lot of things, I mean, risk factors, I would say you have got in this case, right? So do you feel anxious about the future sexual encounter? Yes, doctor, I do feel. Now, what I would like you to do here in this scenario, the management is lifestyle only. Removal of that stress, get rid of that stress, yoga, meditation, maybe Kegel exercise, and all those things, isn't it? So, in this station, I would like you to take proper lifestyle history, psychosocial history, because the management is lifestyle management only, right? So, any medical, any previous STI that you can ask, smoking, alcohol, diet, that is a detailed history you need to take. If patient is a smoker, no smoking. Drinking alcohol, don't drink alcohol. So that is going to be very, 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 very important as well. I would like to do general physical examination, vitals, and maybe private area examination, routine bloods, and maybe urine dipstick. That's something you can do, right? Now, so do you have any idea what's going on? Have you thought about this? What might be causing this? So I think it was her comment. He knows like it was the girl comment that I'm not able to carry out myself properly and I'm feeling low. So it messed up with my head. What are you more concerned? So if it happens again and I won't be able to have sex normally, what do you hope to get from this consultation? I just want to be normal again. Ice is your best test friend. So based on the things, based on what we have discussed, what we feel, you have got performance anxiety, which is common, especially during first time sexual intercourse, and anxiety can cause a temporary loss of erection, but this does not mean you have erectile dysfunction. So management is reassurance, reassurance, and more reassurance. So this was a first time event and does not mean you have a medical problem. Anxiety and negative thoughts can interfere with your sexual performance. So lifestyle advice is reduce stress, healthy lifestyle, and limit alcohol and smoking. So try deep breathing exercise, mindfulness or meditation, regular exercise, balanced diet, good sleep, no smoking, no alcohol. So lifestyle, 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 and more lifestyle. Focus on self-confidence, that's the thing. And if needed, I mean, we can refer you to a psychologist for CBT as well. I mean, that's not required at the moment, but if needed, we can put you in contact with them as well, right? Are you going to give any medication? No need. There is no need. Sildenafil Viagra is not recommended unless there is a physical cause. I mean, patient has got diabetes, a patient has got problem with the blood flow, isn't it? Problem with the blood flow. Any clot, atherosclerosis if a patient has got. Then maybe we might be thinking about the medication, but this patient, young patient, and the problem is just a performance anxiety, no need for any medical treatment, right? So that's the scenario that you have got for performance anxiety. All right.